So I'm going to talk on a case that follows Cal's perfectly, just like Mano said. My disclosures really are not related at all to hemodynamic support. I'm just going to show you first a brief proctored case from Oklahoma City. This was this physician's first retrograde case. He had already tried this antegrade on a CTO of the right coronary artery, but this patient wasn't a surgical candidate because of comorbidities. He's in his 40s, which is a little unusual, and has an ejection fraction of 20%. And the first time they tried him antegrade, the wire went way offline, and the patient became very ill and ended up with a balloon pump and intubated. And so they brought him back and said, hey, we'll fix the LAD first, which they did before I came in, but they already had the Impella in. And then we decided this time to primarily try a retrograde approach, make a little bit of antegrade progress. And I'll just go through this kind of briefly. So he's got this was a CP, an Impella CP, and you can see the microcatheter come down. He was able to get through the septals nicely. The wire follows the calcium, initially a Shion, and then he was able to switch out and actually wire true-to-true retrograde, so it didn't turn out to be that long or a difficult case. He did not have to do reverse cart. It is kind of nice to have that retrograde wire to guide you a little bit. But it also gives you the time, if you've got support, to do the things that Cal did. If you need to do rotablator, if you need to IVUS, you can go ahead and get the nice result you need, the optimal result, without being rushed because the patient's having trouble breathing or hypotensive. And then you're able to go ahead and finish the case. So I'm just going to mention, as you know, there's a lot of different options for hemodynamic support. Practically, for protected PCI, if you're doing a high-risk PCI, it's not a shock patient or an acute patient. Most of the time, I think in this room, it's probably going to be Impella for the kind of cases you're seeing this week. But we do have other options. The balloon pump we'll discuss. There's also tandem heart, and ECMO, I think, is a great thing to have at your institution for the reason even Cal mentioned earlier. Occasionally, it gives you some extra options if you need it. There is some great data. This is a meta-analysis of 90,000 patients from multiple trials, just looking at complete versus incomplete revascularization. Some of it's randomized and some of it isn't, but definitely I think most of us do feel if a patient can get complete revascularization, there's growing evidence that that is the best option. And if you can do all of these different techniques and do it with support and have the time to do it, it's nice to get as much complete revascularization as possible. There was a trial called the BCIS trial that looked at intra-aortic balloon pumps to support patients. It was a balloon pump versus no balloon pump high-risk trial, just 300 patients, ejection fractions under 30% with severe coronary disease, and they really looked at 30-day composite MACE. And the composite MACE on the left, which was the primary endpoint, didn't really have any significant difference, and all the endpoints were similar. It's not a large trial, but I think most people feel balloon pumps just don't give us the support we need frequently for these types of cases. And then probably the landmark trial, which was not a CTO trial. We don't have great data on this in CTO patients, but this is the trial that probably applies the most to the patients that we're talking about this afternoon, was a PROTECT 2 trial. And this is a randomized trial in protected PCI, so these were not shock patients that came in emergently. These were elective or semi-elective patients that had severe LV systolic dysfunction, and they were either interventions on a left main, an unprotected left main, or a single remaining coronary or multivessel disease. And they looked at balloon pump versus Impella, and it was primary endpoint was a 30-day major events. And the trial was actually stopped early because of futility. At 30 days, they weren't showing much difference, but they followed the patients on out. And you see a couple of interesting things, including in the intention to treat on your left at 30 days, it looks fairly similar, but the curves continue to separate out to 90 days. And if you look at the per protocol patients, the difference, the delta is even larger. I will say, so there's less MACE, but this was really based mostly on recurrent ischemic events and recurrent interventions. So the mortality stayed the same. So this isn't really to necessarily say that we improve mortality using hemodynamic support. I think there are cases where we certainly get away with stuff we wouldn't. But for sure we can say that it allows the physician to do a more complete revascularization, do a better job if you need to do rotablator like Cal's case, I know Stefan was mentioning if you have to do rotablator in a patient with a terrible ventricle, you're almost asking for trouble, so it's nice to have support. There are guidelines. There's several that at least address support, and this is a consensus document from ACC and SCI. There's also our more recent AUC guidelines that really don't mention support, but they tell us that most of these patients, if they're symptomatic, ischemic, and have multivessel disease and LV dysfunction, they're almost always appropriate. And then based on the FDA indication this is the FDA indication for Impella, the exact or fairly close wording, I paraphrased it slightly, but the indication is worded for the 2.5 and the CP device that it's indicated if you have a high-risk PCI performed in an elective or urgent patient who's hemodynamically stable and has severe disease with depressed LV function. And they also include when a heart team is used, to look at the patient and make sure you think PCI is the right approach. So the case Cal showed is great, but the people you want to at least think about this in are patients that have poor LV function, and maybe you're going to do a retrograde CTO, so you may compromise the left coronary system with microcatheters, especially if they're diseased. If you're doing multivessel intervention with CTOs, if you need to do atherectomy, especially rotational or orbital, I think laser is not as big a deal because you don't send as much downstream. And also if you're going to have to compromise certain territories with contralateral equipment. Things we have to at least think about, these CTO patients tend to be more sick and more comorbidities, so they commonly have vascular disease, and it's important to at least assess the vascular system. A lot of times people will do an angiogram before they put an Impella in the groin. Subhash Banerjee had a great discussion earlier this week on axillary access, which I think I can only imagine that's going to grow tremendously as people get more comfortable with it, because you can very safely and quickly use the axillary artery for Impella. It's large enough, you can pre-close it. If you know if you know kind of the technique and where to stick it and the landmarks, it's a nice option. Usually use the left side. You want to have a good relationship with your surgeons. I think this is critical. If you have you're going to have to have them involved in making the decision to do these kind of complex patients if you want to stay out of trouble. But also sometimes you have to call them. You may have to call them simply to just help you take care of the access at the end of the case. Or it's just better if they know a little bit about it ahead of time, so you're not calling them in the middle of a disaster. So I think the relationship is critical. You can also think about putting a balloon up when you take the Impella out. So if you're taking it out of the axilla, you can put a balloon up from your other access, especially if you have a groin access, but you can do it from the contralateral radial. It's a little more difficult. But you get a balloon that can actually tamponade the area where your Impella goes in or your access site as you take it out to make sure you get hemostasis and don't get a big hematoma there. It can work for the iliac and femoral system as well. I think really the key benefits of using it is it just makes you be able to be more relaxed, be able to do a better job, complete revascularization if possible, optimal vessel prep, and optimal stenting if you need to do IVUS. It gives you the time. And there's some other emerging data that is, I think, intriguing at least, that hospital stays, if you're doing these protected cases, it looked like there was a couple days shorter hospital stays in several data sets. There's less acute kidney injury in one of the propensity matched studies, and then less readmissions, less ischemic events. And the other thing I just learned this week from leadership at Abiomed was that most of the devices going in for protected PCI now are the CP device. The vast majority, it's up to 2/3 and growing. So just like Cal's case, even though you can probably do fine with the 2.5 device in a lot of cases, the CP is where a lot of the innovation is being targeted right now. So they're putting a lot of their future progress toward the CP device, and it's growing a lot in use. The other thing that I was thinking about on Cal's case, checking an EDP before you start, make sure it's not low. You want to make sure your Impella gives plenty of output. The right heart catheter, they're growing a lot in shock patients with support, not nearly as common in just standard angina patients that are being done, but there are patients where it can be very helpful. And also, obviously, complexity is increasing, so we're going to do more and more of these complex patients. This is the last slide. I'll just mention this is from Jamie McCabe up at Bill Lombardi's Center in University of Washington. But there are different algorithms you can use, and I won't go through all of this, but I think it's a great slide because it's a little scoring system. You could say, if you're trying to decide, am I going to support this patient, you might put a right heart cath in if you're not sure you're going to go one way or the other. If the EF's terrible, you get points, depending on the risk of the patient, and there's negative points if the patient has bad vascular disease or terrible hemoglobin. So these can help you sometimes make the best decision, and I think this is a reasonable algorithm. I just put that on there for Manos, and I think that's it. Thank you.
Thank you very much, Tony. This is Santorini, Greece. I wish I could tell you we have the meeting there next year, but I don't think so. I'll still be in Denver next year, so don't keep your hopes up.